All right, let's jump right into it. Welcome to the Explainer. Today, we're completely transforming the MSRA Strategic Study Guide into a rapid, highly focused masterclass. If you're prepping for the multi-specialty recruitment assessment, you already know that acute asthma management is an incredibly high-yield topic. I mean, it is literally loaded with clinical traps, really subtle severity markers, and exact numerical targets you just have to know. So our goal today is to hand you the strategic blueprint to dodge those traps, lock in the facts, and absolutely ace the assessment together.
Here is our roadmap for today's Explainer. Number 1, asthma basics and exam pearls. Number 2, severity stratification and mnemonics. Number 3, acute management protocols. Number 4, safe discharge criteria. And finally, number 5, the MSRA 10-question challenge.
Okay, Section 1, asthma basics and exam pearls.
So, at its core, an acute asthma exacerbation is defined by the progressive worsening of dyspnea, wheeze, cough, and chest tightness. It happens over an acute or subacute time period, and, this is crucial, it requires urgent medical intervention. Now, when you're intervening with beta agonists, it's actually fascinating and honestly vital to spot their adverse effects in exam vignettes. You really want to keep an eye out for a patient who suddenly develops a fine tremor, palpitations, a headache, hypokalemia, cardiac arrhythmias, or, while it's pretty rare, paradoxical bronchospasm.
And that brings us to a massive clinical pearl. When you're advising patients who are using nebulized short-acting beta agonists, or SABAs, the guidelines explicitly tell us to advise them to use a mouthpiece, not a face mask. Why? Well, using a face mask allows the aerosolized drug to escape and literally bathe the eyes, which can actually precipitate acute angle closure glaucoma. It's kind of surprising, right? But it's exactly the kind of highly specific detail those MSRA question writers love to test.
Moving right along to Section 2, severity stratification and mnemonics.
Listen closely, because when you look at the guidelines, there is one golden rule that absolutely stands out. Any single feature of a higher category immediately upgrades the severity of the entire attack. In an MSRA scenario, a patient might have 3 features of a moderate attack, but if they show just one single feature of a severe attack, bam, they are severe, no questions asked. One single feature changes the whole shebang.
Now let's break down how clearly these guidelines delineate the boundaries between categories. For a moderate attack, peak flow is between 50 and 75%, respiratory rate is under 25, and they can speak normally. But watch how quickly that shifts to severe. Peak flow drops below 50%, respiratory rate spikes to 25 or more, and they can't complete sentences. Life-threatening brings terrifying signs like a silent chest, cyanosis, or bradycardia. And near fatal, that means a raised PCO2 or the patient is requiring mechanical ventilation.
And right here, guys, is the absolute MSRA trap you have to watch out for. A quote-unquote normal PCO2, that's 4.6 to 6.0 kilopascals, in an acutely breathless asthmatic is not normal. Actually, scratch that, it's worse than not normal. It is a life-threatening feature. Think about it. An acutely breathless patient is hyperventilating, right? So they should be blowing off CO2, making their levels low. If that level is creeping back up to normal, it means their respiratory muscles are tiring out and hypercapnia is setting in. Do not let the word normal fool you on test day.
To make sure you never miss a classification, the study guide offers this brilliant scan-check default mental algorithm. Step 1. Scan for life-threatening or near-fatal flags first. We're talking exhaustion, a silent chest, or that sneaky normal PCO2 we just talked about. If they're present, categorize the patient immediately. Step 2. If none of those exist, check for severe parameters next, like broken sentences or a heart rate over 110. Step 3. If neither of those are present and peak flow is above 50%, you default to moderate. So scan the worst first, check the middle, and default to the safest.
All right, Section 3, acute management protocols.
Think of management as a sequential staircase based entirely on severity. First off, unlike COPD where you have to titrate oxygen super cautiously, in acute asthma, you immediately hit them with high-flow oxygen targeting 94 to 98% saturation. For a moderate attack, you step up with a SABA and oral prednisolone. If they're severe, you step up again by adding nebulized ipratropium bromide. And as for the steroids, they need to continue daily for at least 5 days.
But what happens if the attack becomes life-threatening? That is when you reach for your life-threatening adjunct. You keep all the previous treatments going, but you immediately add a single dose of IV magnesium sulphate. Specifically, that's 1.2 to 2 grams given over 20 minutes.
And of course, a life-threatening attack means you're immediately getting on the phone for a senior and ITU consultation. Which brings us to Section 4, Safe Discharge Criteria.
The absolute keyword to look for here is all. A patient must meet every single one of these criteria before walking out that door. They must be perfectly stable, entirely off nebulizers and oxygen for a full 24 hours. Their peak flow must have recovered to greater than 75%. Their inhaler technique has to be checked and documented, and they need their steroid course and action plan physically in hand. If they miss even one of these, they stay. No exceptions.
And finally, Section 5, the MSRA 10-question challenge.
Let's put this into practice with question 1. A patient has a peak flow of 60%, a respiratory rate of 22, and a heart rate of 100. So far, everything looks pretty moderate, right? But wait, the vignette says he cannot complete a full sentence in one breath. So what's the severity? Remember our golden rule? The inability to complete sentences immediately upgrades the attack. So the correct severity classification here is severe.
Next up, question 2. A patient comes in completely exhausted with a silent chest, and their blood gas shows a PCO2 of 5.5 kilopascals. How do you interpret this blood gas on the exam? Well, if you said normal, you just fell for the absolute trap. Yes, 5.5 falls within normal numeric boundaries, but in this specific context, it is a life-threatening feature. It indicates massive muscle fatigue and impending respiratory arrest.
Let's rattle off some hard numerical targets examiners love to test. The oral prednisolone dose? That's 40 to 50 milligrams for at least 5 days. For discharge, remember they need 24 hours of stability and a peak flow greater than 75%. And our precise oxygen saturation target is always 94 to 98%. Locking these numbers in your brain guarantees easy marks on the test.
Okay, scenario time for question 5. This tests your knowledge of emergency adjuncts. You have a patient with severe asthma who is entirely unresponsive to nebulized bronchodilators. They're now showing a silent chest and cyanosis. Alongside oxygen and steroids, which intravenous drug is added immediately? The answer is your life-threatening adjunct, IV magnesium sulphate, 1.2 to 2 grams over 20 minutes.
Let's bring it home with this final rapid recall. For nebulized salbutamol, you always advise a mouthpiece to avoid glaucoma. The specific blood gas marker for a near-fatal attack, that's a raised PCO2. And that second-line inhaled agent for severe attacks? Nebulized ipratropium bromide.
This just brilliantly illustrates how interconnected all these guidelines really are. We've tackled the sneaky blood gas traps, the precise numerical targets for discharge, and the critical clinical pearls that will definitely set you apart. So I want to leave you with this provocative thought to ponder before test day. When you're frantically scanning through a dense, stressful exam vignette, are you ready to spot that single feature that changes everything? Keep the golden rule in the back of your mind. Trust your scan, check, default system, and you are going to do amazing. Thanks for joining me on this explainer, and happy studying!